Let's talk about joints, shall we? Joints, another term for them is articulation, is any place where two or more bones meet. That's it. That's the end of definition. They don't have to be movable. There are two classifications of joints based on the function and based on the structure. Functional classification is based on the freedom of movement. Synarthrotic joints are non-movable. Amphiarthrotic joints are slightly movable. And diarthrotic joints are freely movable. Structural classification is based on how bones are connected. If they are connected by connective tissue, the fibrous joints, most of them are immobile. Very few of them are slightly movable. Cartilaginous joints, in which bones are connected by cartilage, are pretty much not very mobile. Okay? And finally, synovial joints. These are freely movable joints. So we're going to discuss each structural type separately. So fibrous joints. Connective dense, regular connective tissue, no cavity. Most of them are immovable. So three joints that you must know, joint types. First are sutures. Sutures are between the bones in your skull. Okay? We talked about sutures such as coronal, squamous, sagittal, and whatnot. Syndesmosis. Not in the skull, two bones are held together by a ligament. So, for instance, distal fibula-tibial joint here. Also, for instance, radio-ulnar joints. Okay? And then a very specific type, gymphosis. So this is the joint formed between your tooth and the alveolar processes of either maxilla or mandible. Obviously, they're not movable, at least not voluntarily movable. Okay? And the connection is by the periodontal ligament. Cartilaginous joints, so we have two types. First is synchondrosis, when the bones are connected by hyaline cartilage. So technically speaking, the epiphyseal plate found in the epiphysis of the bones of growing children is a temporary joint. More common, ribs and sternum. Okay, classic synchondrotic joint. Symphysis. The difference from synchondrosis is that the bones are connected by fibrocartilage. So effectively, we're talking about all intervertebral discs. Those are all symphysis joints. And pubic symphysis. Okay, sounds good so far? Nice. Now, you may have noticed that so far, as we were talking about these joints, all of them are either immovable or have very, very, very limited mobility, such as symphysis. The only freely movable joints in the body, the only diarthrotic joints, are the synovial joints, which have dramatically different structure compared to fibrous or cartilaginous joints. So there are certain bits that are common for all synovial joints. First of all, articular surfaces of the cartilage. So this is your articular cartilage. Okay. Then we have the cavity. It's important that joint cavity is filled with a synovial fluid. As any other fluid in the human body, synovial fluid is produced by filtering blood, so it contains a fair amount of plasma and a fair amount of hyaluronic acid. Now, it's added to cosmetics. I don't really know why, because there's no, yeah, there's not really serious physiological basis for adding it to, personal hygiene items. But here's the idea. First of all, it lubricates. Second, it nourishes the cartilage. Okay? Now, you can imagine, since this is not blood, the oxygen delivery and delivery of resources that are otherwise required to heal, for example, the cartilage, it's subpar. So as we will see, cartilage doesn't really heal itself, even more than that. And it does contain white blood cells that remove debris, and we'll get to why this matters. Okay. So synovial fluid is produced by the synovial membrane. Okay, you can see synovial membrane here. Its function is to filter practically all cells out, leaving only plasma within the joint. Now, obviously, this cavity cannot exist if there are no strict boundaries. Those strict boundaries provided by the joint capsule. Since joints, synovial joints, have a fairly good freedom of movement, the forces that act on the joint capsule or articular capsule can be directed in multiple, directions. Okay? So this is why the joint cavity is formed by the dense regular connective tissue. Dense irregular, my bad. Joints are reinforced with ligaments, pretty much any joint. Ligaments can be capsular or intracapsular, very rarely extracapsular. So capsular ligaments often form a part of the joint cavity. This is why we call them capsular ligaments. Intracapsular ligaments are entirely contained within the joint capsule. They are inside of the synovial cavity. In other words, I can illustrate it. For instance, let's put the ligament here and here. I'm just messing with it. But the idea is that this will be intracapsular. Okay? Obviously, there's a fair amount of nerves for proprioception and for pain, and blood vessels. Blood vessels run not through the joint, but mostly through the synovial cavity, the synovial membrane, I'm sorry. Now, the structures found in all synovial joints, but there are some that may or may not be present. First of all, fat pads. Here on this schematics for the knee joint, you can see infrapatellar, the fat pad that is located inferior to your patella in your knee joint. Knees, and only knees, have menisci, articular discs. So you can see, can you? Okay, so I'm gonna highlight where meniscus is. So this is just a lateral view of the meniscus. Menisci improve the fit within the joint and also provide extra cushion. If you think about your knees, that kind of makes sense, because at the end of the day, the weight of pretty much your entire body lands on the knees, okay? And then there are bursae and tendon sheaths. So let me explain what these are. On the image to the right, you can see infrapatellar bursa and prepatellar bursa. These are bearings, okay? Let me explain what I mean. You're all kind of familiar with the bearing, right? So imagine I need to move something heavy on this floor, and I don't have a dolly, okay? Very big and bulky and heavy. So what I'm going to do, check this out. I'm going to torture you with my drawing again. So imagine that this is the surface, right? Oh shit. Hold on a second. Let me make it thinner. I forgot that I changed it. So this is the surface. Okay? This is the object. So what I'm going to do, I'm going to put like little rolls under it and just roll this object by moving those bearings in front and so on and so forth. Does it make sense? The whole idea. This is bursa. Inside of the bursa is synovial fluid. Okay? So effectively, when you look at this image, that gray stuff in the bursa is the synovial fluid. So bursae prevent the friction between, let's say, the skin and the bone, as in case of your knee joint, or between two bones. Or, in some cases, imagine you have a tendon that can kind of rub against the bone. To protect this tendon, it is wrapped into a tendon sheath. Okay? Now we're going to discuss several joints, synovial joints, I mean, and we're going to compare them based on their stability. So, the factors that contribute to the stability of joints, there are three of them. We're going to rank them from the least to most important. Bless you. The least important factor, surprisingly, is the shapes of the articular surfaces. In other words, how bone surfaces fit into each other. Spoiler alert, in many cases, they don't really fit. Look at the knee joint. They do fit, but there's not a lot of grabbing, retention, call it whatever. Okay? Ligaments. Number of ligaments, the position of ligaments. More important, but still not most critical. And finally, muscle tendons. So your joints, the synovial joints, since they are freely movable, it means that there are muscles that cross that joint. For instance, quick thing like shoulder joint, two large muscles that cross it is pectoralis major and latissimus dorsi. Okay? So this muscle thing is the most important factor of joint stability. Okay? And we will discuss how it is a clinically relevant information. So now let's talk about different joint types based on the movements that they can produce. First one, of course, is pivot joint. Okay? So pivot joint can be found between the first and the second cervical vertebrae. Remember I showed you last week atlas and axis on the image? How the dens of the axis that sticks up is the axis for the C1. Then you have hinge joints. There are several of them. One of them is the elbow joint. Then I have a saddle joint. Okay, this is the first biaxial. Do you understand the term biaxial? So there are two axes around which the bones, the joint can move. So effectively, look, in this representation here, it can rock back and forth, okay? And it can rotate a little bit. So two axes of movement. Plane joint, begrudgingly multi-axial. I prefer to say that plane joint doesn't really have the axis of movement because it's a gliding movement. I'm going to give an example. One of the temporomandibular joint, there are actually two of them, but there is a gliding joint there. Look at my jaw. Okay? Protraction, retraction. Also your tarsals and your carpals form gliding joints. Condyloid joints, radius and carpal bones, biaxial. And ball and socket, truly multi-axial joint, shoulder and the hip. Okay, so now let's talk about the movements. The word flexion is used for the movements that occur in the sagittal plane. So, sagittal plane or transverse plane. Flexion is referred to the situation when the angle between the limb and the axis of the body decreases, and extension is when the angle increases. So let's illustrate this. When you are frontally raising your arm, it's a shoulder flexion. When you move it back, it's the shoulder extension. So flexion is when you like raising them. Basically, do you mind if I'm going to speak sometimes in the gym terms? Frontal raises, the exercise for shoulders. Yep, that's flexion. When you, no, that's like just this. Okay? When you move it back, that's the shoulder extension. Okay? When you bend the knee, that's a knee flexion, because this is the angle we're talking about. Okay? Move it back, knee extension. Bending, when you bend the knee, I mean, if you bend the knee forward, you're injured. When you bend the knee, in my experience, bend the knee, it's only one way. That's flexion, right? When you straighten up the knee, that's the extension, yes. Okay? So flexion, extension. Now, same is true for instance your head. The flexion of the neck is when you say yes. And then when you put it back, get your head up again, that's extension. Generally speaking, when you move your head beyond, like backwards beyond the axis of your body, like when you start looking up at the sky, that's hyperextension. Same is true with your arm. when you not just put it back, like you raised it frontally, then you put it back, and then start moving it posteriorly, that's hyperextension. When you do the sit-ups, okay, it's a flexion of a trunk when you take a bow, okay, that's a flexion. When you straighten up, it's extension. When you move all the way back, like, again, you're looking at the sky, I use the term hyperextension. Now, let's take a look at the coronal plane. Remember, the plane that separates your body into the ventral and dorsal compartments. So when you are doing lateral raises, in other words, that yes, like you pretend that you're a bird, okay? You know, when you spread your wings, so to say, you abduct your arms away. No, that's flexion. That's a trick. The movement in transverse plane, that's flexion. Sagittal or transverse, flexion. Sagittal, angular are the ones that, concerned with an angle. Okay? Now, abduction and adduction refers to the limb movements that occur in the coronal plane. When you're a bird and you raise your wings, you abduct, you remove, you steal your arms away from the body. Does that make sense? You steal them. When you bring them back, you add them back to the body, so it's adduction. Okay? Add means adding, like adding. Okay? Now, a pretty weird movement called circumduction. So, the images don't really do the justice. You can look at me. Yeah, that's circumduction. You're trying to draw a circle with the tip of your fingers or toes. You can do circumduction with your leg as well. But the point of attachment sort of remains like that. It doesn't move effectively, the point of attachment. I want you to distinguish clearly between circumduction and rotation. Okay? So, if you do this with your head, unfortunately we cannot record that movement, don't have a camera, but this is circumduction. This is rotation. Yes. When you do this, this is circumduction. Now try to straighten up your arm and rotate it. Your shoulder can rotate. That's rotation. That's a completely different motion. Okay? That makes sense? Okay. Rotation can be, well, directional, especially with the legs. So lateral, when you rotate, that's rotation. Yes, that is rotation. Okay? Now, lateral versus medial rotation, yeah, with your leg, if you're basically, if you stand and like you stand on your feet, right? You look at your toes, you turn them without stepping, just outside, just like this. That's lateral rotation. You turn them in so they face each other. That's medial rotation. Yeah, just medial rotation, lateral rotation. Pronation and supination. So fairly easy. When something, well, it applies, first of all, it applies to your forearm and your palm. When your palm faces down, it's in the prone position. When you turn it to hold a bowl of soup, this is the supine position. Okay? Supination. When you're holding soup, supination. When you're not holding soup, pronation. I don't know if anyone was exposed to that terminology during the first year of COVID pandemic, when it was shown that patients on respiratory support in the hospitals fared dramatically better if they were placed in the prone position, on their face down. And they actually started designing like pillows and all kind of stuff to allow that to happen. It increased chances of survival by tens of percentages. So we are now into weird movements. So dorsiflexion is applied exclusively to your feet when you walk on your heels. Your ankle is in dorsiflexion. When you walk on your toes, it's in the plantar flexion. Okay? When you walk on the lateral edge of your foot, it's inversion. When you walk on the medial, it's eversion. Okay? Does that make sense? I can't really, I can show, but I will need to climb up on the table for everybody to see. You get the gist, I guess, right? So again, like look at your feet, try to stand on the outer edge. You don't have to stand, but that's inversion, okay? On the outer, the lateral, outside of your foot, inversion. Staying on the inside is eversion. I know it sounds counterintuitive, but the idea is that when your feet are in the inversion, it means that they kind of come closer together because you stand on the outer edges. And when they are in the eversion, that they're getting farther from the midline. So protraction and retraction. Here we have mandible. You can do protraction and retraction without that rather embarrassing movement. If you sit sort of, relaxed, try to move your shoulders forward without moving anything else, like this. You protract your scapula. When you move them back, you retract your scapula. Okay? Elevation and depression. So, when you chew, yes. Much simpler, when you shrug. Shrugging is elevation. And then going back to the previous position is depression. Okay? When you open your mouth, you depress your mandible. While you close your mouth, you elevate your mandible. And opposition, thumb and all other fingers. Okay? So when you form like an OK sign, this is an opposition. Okay? Now we're going to chat about some anatomical features of the key joints. I'm not going to go into a lot of bursae and fat pads, and will instead focus on key ligaments, not even tendons. So, hear me out. So this is your knee joint. Let's take a look at some of the ligaments that form. In the knee joint, ligaments actually form a big chunk of the articular or joint capsule. So in the front, you have patelloretinacula and patellar ligament, okay, that form the front part of that joint capsule. Now remember, the difference between the tendon and the ligament is that tendon connects a muscle and a bone, and ligaments connect two bones. So if you think about the structure of your leg, the knee joint is the place where four bones meet. One of them is femur, another one is patella, okay? You have tibia, And technically speaking, you also have fibula there. Although knee does not articulate with the fibula. Okay? There's no joint, there's no joint between the femur and the fibula. Okay? So that's the front side. On the sides, fibular and tibial collateral ligaments. You can see them here. So tibial collateral, or TCL, and fibular collateral, or FCL. Okay? And then, if you look at the back of the knee, not on this image, we don't have this view, but on the back there are two popliteal ligaments that connect the femur and the tibia in the back, and they prevent your knee from hyperextending. Who was that running back? Was it Brown's running back that got his knee bent the other way? But no, I think it was last season.
Oh yeah,
Nick Chubb, yeah. That was not supposed to happen. This is hyperextension. What he went through was hyperextension of the knee, and those ligaments were definitely snapped along with a bunch of others. Okay? Now, we figured that those back ligaments prevent your knee joint from hyperextending. You also have two very famous. I'm actually going to go back here and show them to you first. So you have two famous ligaments, ACL, or anterior cruciate, and PCL, or posterior cruciate. So I want you to take a look at, ACL first. So if you look at this image, that's a bit too thick. Hold on a second. So this is the front of the tibia. Okay? The term that we use for the front is anterior. So this is why it's ACL. This ligament, you can barely see it, but it is attached to the tibia in the back. Therefore, it's posterior cruciate ligaments. They are small, and they are relatively weak. They prevent the displacement to the front and to the back. Okay, so, so basically, look at my hands. This is tibia. This is femur. So what these ligaments prevent is the movement of tibia front and back. Okay? Does that make sense? We can tear them because they're so weak. Weird movements, quick flexion, especially if the flexion is associated with the anterior displacement. Let me explain it in easier terms. Imagine somebody gets tackled, football is the easiest for this, from the back into the knees, falls backwards, knees bending, and there's a dude basically blocking the tibia. So the force that will be applied will be such that in addition to the normal flexion, your tibia will be pushed forward, and that will tear that. It has limits. Every ligament has limits. Like, I can probably fall back and be fine, but there is a limit. If I'm falling over 300-pound dude, I'm getting my ACL snapped. Okay? So ACL is, hold on. here. We'll get to the torn one, don't worry. Okay? So the common ACL tear is the side tackle or, side hit. So when you see the direction of force, right? The first thing that snaps is actually TCL, tibial collateral ligament, on the opposite side. So you getting tackled from the outside, shoulder to the knee. Does that make sense? Which means the force is applied that will go like this on the TCL, which means it's going to snap. Now your knee joint isn't stabilized as it should be anymore. Now ACL snaps. And if the force is large enough, the ACL tear can also facilitate a torn meniscus. Okay? Sort of a... You can get the torn meniscus from the tibial tear, yes. Yes. Menisci are, I don't want to say designed, intended to absorb vertical force. That's what your knee is good for. Absorbing vertical force. Okay? By the way, multiple studies showed that moderate running does not negatively impact your knees. Okay? I'm not talking about running like 80 miles a week. That's a different story. But it's not behind, it's from the side. So imagine your right knee is being hit from the right. Okay? Yeah, no, it's from the side. Does that make sense? So overall, but here's the deal. Knees in general are pretty stable joints. It's not often that people dislocate the knee. It's not easily dislocated. And it brings us back to the most important factors that stabilize the joint. Knee joint is crossed by several pretty large muscles. We're talking hamstrings, we're talking quads, we're talking calves, gastrocnemius. Okay, so all these big strong muscles stabilize the knee. Now, not opposite, but sort of very different is the shoulder joint. So type-wise, it's a ball and socket, which shouldn't come as a surprise. The most freely movable joint in the human body. Okay? A little digression, sort of. I have a question for you. The closest evolutionary animals to us are great apes, like chimpanzees and gorillas. Let's take chimpanzees. They are genetically the closest. The anatomy of their shoulder and the anatomy of human shoulder, are they largely the same? What do you think? They're drastically different. Well, not drastically. Human shoulder, over thousands, practically a million years, was selected to do what? What do we do that nobody else in the animal world does? We're very good at throwing things. We're very good at it. I mean, chimps can throw, right? But they can't throw to kill something. Humans hunted using spears. Human shoulder, evolutionary adapted to throw things. Look at baseball. Look at football. Like, we're really good at it. Make sense? So, that comes from freedom of movement, but there's a downside. It's often dislocated. Why? Well, first of all, muscles that cross your shoulder joint. Biceps, triceps, rotator cuffs. Overall, biceps, triceps, coracobrachialis, rotator cuffs, they're small muscles. That makes sense? And I'm not saying that they're relatively weak. They're not. But they, in absolute terms, they weak compared to, say, hamstrings or quadriceps. So shoulder joint isn't particularly stable because of that. And the ligaments. So here you see a bunch of small, really not important, like coracoacromial ligament. Do they have? No, they don't have the coracohumeral ligament. They barely show glenohumeral, but I can tell you what it's like. So if you look at any of the Benjamins in the class, okay, you can see the little cavity, the glenoid cavity, in the scapula and the head of humerus that sticks in there. Extend this cavity further by building a ligament wall that will hug the head of the humerus. That's done by glenohumeral ligaments. The thing is, they are weak, and in some, like, they're not even standard in different people. Some people may have more or less stable shoulder because of different number of glenohumeral ligaments. Okay? So far, does that make sense? Now, it is what one of the most common dislocations of the shoulder joint occurs in kids. Well, first of all, it's unstable. Second of all, there's a specific parental activity that gives kids. Yep, swinging kids by holding their hands. Okay? That dislocates shoulder joint all right. Okay, it can be popped back in. If you want to see a really cool video, I don't remember how, like I Googled it on YouTube. You can Google American rugby player, dislocated shoulder. Remember, rugby is a football for real men. And he's being tackled. The tackle dislocates his shoulder joint. You can see it. With a free hand, he pops it back in without even leaving the game. And just keeps going. Okay? You can do that. Elbow joint. The hinge joint. Main movement is provided by the hinge between the trochlear notch of your ulna and the trochlea of the humerus. Okay, there is a joint between the radius and the capitulum of humerus. Now, the ligaments that reinforce. First is radial collateral. You already learned that collateral is the side, so radial collateral connects radius and humerus. Ulnar collateral, same idea, but it connects, well, ulna and the humerus. And then there's annular ligament. So annular ligament is basically a loop, okay, that allows pronation and supination. When you will be working with the bones today in the skeleton, I encourage you to do this, like a pronate and supinate Benjamin's forearm, and you will see how ulna and radius move next to each other, and the ends remain stuck together because of the annular ligament. Only two movements, flexion and extension. You're not supposed to hyperextend your elbow. Okay. Now we look at the hip joint. Ball and socket just like shoulder, but way more stable. So basically, if you look at the shoulder versus your hip, you can clearly see the trade-offs. Greater degree of motion in the shoulder has a downside of instability. Lower degree of motion in your hip has an upside of greater stability. So, why? Well, first of all, when the head of a femur fits in the labrum, that's pretty good fit, right there. Second, fits in the acetabulum. I misspoke. When the head of the femur, this, fits in the acetabulum, that's a pretty good fit. Another thing is, on the ridge of the acetabulum, there's an extension made out of cartilage. Okay, you see that green stuff? So this is extra cartilage that built on top of the bone that improves the fit, kind of hugs the head of the femur even more. Then there are ligaments. This ligament, often called a ligamentum teres, and 3 pretty thick ligaments that connect pubis, ischium, and ilium to the femoral neck. So here, iliofemoral ligament connects ilium of the coxal bone to the femur. Pubofemoral ligament connects pubis. So let me highlight some of the things. So this is pubis. This is ilium. Okay? And then the back part, the ischium, is connected to the femur by the iliofemoral ligament. And again, you can see, like, dislocating a femur is a really daunting task, because because your hip joint is crossed by a huge number of pretty strong muscles, all the glutes, a bunch of internal muscles such as psoas, iliacus, gemellus, okay, piriformis. They short, and remember, the shorter the muscle, the stronger the force that it can produce. Short muscles are particularly strong because they don't have to deal with this massive fibers, okay? So they're pretty strong, so they stabilize the hip all right. Which brings us to the unstablest. No, not the unstablest. One of the easiest joint in the human body to forcefully dislocate, TMJ, temporomandibular joint. So there are, as you can see, 2 joints. One of them is gliding, that's your superior joint cavity. And one of them is hinge. This is the inferior joint cavity. Okay, they separated by the disc, by the articular disc. So the movements are side by side. Technically, we can protract and retract, and obviously depression and elevation. Now, this is, I'm going to tell you, to lighten up today, I'm going to tell you a little story, which you, if you watched review videos, may have heard. It's my favorite story. Allegedly, it happened. So first of all, I can totally see that it could happen in Russia. Like, that's mentality of my former compatriots. So 2 guys, let's name them very Russian-sounding names, John and Bill, sit in the kitchen drinking whatever, alcohol. They get pretty drunk, and one of them says to another, say John tells Bill, Bill, I bet you can't put a light bulb in your mouth and then take it out. Bill says, no way. Grabs the light bulb, sticks it into his mouth. Lo and behold, can't take it out without cracking it. So what you're going to do, right? It's like 1 a.m. in the morning. So in Russia, the emergency thing, you are not, okay, the Russian emergency is mostly focused on trauma. So if you have some kind of small fracture or some laceration, you can go there, they'll fix you, and you go home. It's a walk-in, okay? And that can be pretty severe. Like, you can walk in the trauma and there's going to be someone with like a stab wound, something like that. And there's a kid who, I don't know, dislocated his shoulder. They will be sitting next to each other. And it's open 24/7. So they call a taxi, and they go to the closest trauma. They walk in, and the physician's like, okay, we have two drunk idiots. He dislocates the TMJ of Ben, takes the light bulb out, gives it back to them, which was a mistake, and they go back home. And John, who offered the bet, says, cannot believe you couldn't take it out. Takes the same light bulb, sticks it up his mouth, and can't get it out. So now Bill calls taxi, and they go to the same trauma because they're local. And the physician has a good blast of fun taking the, dislocating second TMJ. So they have and he makes the same mistake and gives them the light bulb back. On the way home, the taxi driver, who I must say was the same guy both times, says, I can't believe you couldn't get it out. Grabs the light bulb. Yeah. I can totally see some of the people I grew up with doing this. Like, I know some crazy stuff that my friends did. Okay? So now let's get to the fun part. Don't, please.
No, I want to know what your stories are now.
What?
What your stories are.
Oh yeah, there are some. I was pretty boring, but my friends were not. So, okay. Tears. Let's start with the cartilage. Cartilage, generally speaking, doesn't heal. No, it's a bow. Patellar. Patellar bow. Yes. Okay? Now, we're going to focus on the meniscus. Shear stress. What does that mean? Shear stress is the force that is directed not as a compression, but like a sliding force. Okay? So I'm going to use one of my kids to illustrate how it works. So he climbs, free climbing. And turns out when you free climb, I didn't know that, legs are pretty important. And the moves that you have to pull off with your legs are weird. So he probably injured it first or second year, didn't pay attention, and then his knee got twisted by a wave in the ocean, basically like rotated sideways. And that shear stress contributed to the damage, and eventually the fragment of a cartilage started locking his knee. He couldn't extend it completely. So he went for this arthroscopic surgery, and they removed, it wasn't a huge bit, so they just removed the fragments, said just, be chill. The whole surgery took like 30 minutes. Once he was in this, I was hoping to work. I was in a hospital, like the time I set everything up, I see that his name, like he's ready to go. He walks out. This dude walked out on his legs. Now, sometimes the meniscus can be repaired because that same fella tore his second knee climbing. This time they went for fixing. So they put some staples pretty much. They stapled the bits, and it healed, and he recently reported to me that he finally gained the full range of motion. Okay? It wasn't 30 minutes, it was a little bit more. Now imagine that you are not the recreational climber, but a professional football player who often experiences those shear stress forces. So bits of your meniscus start falling apart. They're being removed. Meniscus doesn't heal. When part of meniscus is gone, the stability of your knee decreases, inevitably. So you become more prone to the injuries. At the end of the day, you lose the entire meniscus. This is called osteoarthritis, when the ends of the bones start rubbing against each other. That causes inflammation, and that we'll talk may result in complete immobility. You can replace the affected joint by a prosthetic joint, but it's separate surgery. Okay, sprains refers to the ligaments. Okay, you stretch them or you tear them. Also, slow repair. Okay, because there are no blood vessels and the only way the factors required for repair are going to be delivered is through the synovial fluid, which is not really optimal. Okay, so there are options for treating. You can sew them together, which is kind of not great, because if you think about the tissue, it's a dense, regular connective tissue, so all the fibers, it's not going the same direction. It's not a lattice like a regular fabric. Okay, you can graft a ligament. Okay, one of my colleagues, well, you can graft a ligament or a tendon. You can take it from a cow. We had a joke that one of my colleagues tore his the tendon of pectoralis major muscle, lifting, and he got replacement tendon from a cow, and we had a joke that he had a cow boob job because it was in his thorax. And time and immobilization. There's a fourth treatment which is not spoken about, human growth hormone, which is reserved mostly for athletes, mostly for football players. I still remember, well, I'm not really following football anymore, so all my memories are from 15 years ago. Adrian Peterson, one of the greatest running backs of all time, got complete ACL torn. It's just shattered. Next year, second most running yards in the history of NFL. Next season. He played for the Vikings at the time, and I think they made it. I don't remember if they made it to Super Bowl, but it was a pretty good season for him. But it was age, 100%. They all are on the hormones, and off-season, everybody's taking it. Dislocations, kind of discussed it. Okay, you can see the dislocated interphalangeal joints here. Subluxation, partial dislocation. Again, one of the kids had a partial dislocation of the elbow, and it's interesting. He didn't have any discomfort, but we noticed that he could not reach his ipsilateral shoulder, so he couldn't do that. His hand stopped like this, and it was in the physician's office, and the physician like, oh, we're going to pop it back. Just squeezed it in. Okay? Make sense? Now, I wanted to bring my own experience to the stability, to give you an idea why, what's important. So, for about a year, for various reasons, I was not regularly exercising. I barely went to the gym. And eventually I went for a run, several runs, and lo and behold, I progressively injured my ankle. And I went through the physical therapy, and I started exercising again, and that physical strength is what keeps me away from that injury that I'm very prone for. So, as much as I like running, I totally acknowledge that the best exercise is the resistance training exercise from the health perspective. Inflammatory conditions. Bursitis. inflammation of bursa. Imagine that you are working, doing something, and you stand on your knees, okay, and you move around. That constant pressure may result in the inflammation of bursa, in bursitis. Anti-inflammatory drugs, it goes away. Tendinitis, old man disease, okay? When you constantly, especially when you subject your tendons to not just steady force, but to the bursts. This is why it's called, I don't remember which one, I don't remember which tendon is which, but there's a tennis elbow and the golfer elbow, right? So the opposite, because in tennis, when you do the backhand deflection, that is a burst of force applied to one of the tendons, and in golf, when you hit the ball, it's the resistance also applies. So basically what I'm saying is you can lift 400 pounds and not having tendinitis because it's not a burst, it's sort of a slow effort that you develop. Treatment, non-steroidal or steroidal. Turns out I spoke to an orthopedic surgeon. There is a surgical procedure when they will go in, basically remove the inflamed part and reattach the tendon to the bone. Okay. So again? That's a great question. I don't know. Usually, is it? That's the elbow surgery?
I think so.
Yeah, I'm gonna check it. And yeah, you see, I'm not a big fan of baseball. I don't care about the health of people who get $20 million a year. Okay, arthritis. In general, arthritis is the inflammation of a joint, period. Okay, there are several types. First is osteoarthritis. So wear and tear. That's your arthritic hip. Okay? Now, I want you to know, like, wear and tear, first of all, there's normal wear and tear. We're all going to develop osteoarthritis to some degree as we become older. Okay? Then there is sometimes sort of misalignment of the joints. That will also contribute. When the articular cartilage is pretty much gone, the bone ends become thicker and start to restrict the movement of the joint. Now, interestingly, so in arthritis, movement is painful. It's also necessary, because if the joint is not moving, then it's going to become immobilized eventually. Okay? Now, one more nail into the coffin of the dietary supplements. Chondroitin, glucosamine, and all other crap for the joint, for, quote, joint health, are absolute bullshit. As well as collagen. All of that is crap. Collagen, chondroitin sulfate, glucosamine. I looked up studies of their effect on the joint recovery or joint stability or offset of arthritis. None. Period. None. So don't waste your money.
What is purple?
The what? That's inflammation of a nerve. One of the nerves, probably ulnar. No, probably right, medial nerve. Probably medial nerve, because clicking's here. So just, enjoy your time and be ready for the best thing to do. Go ahead.
How do they provide cures for that?
There's no cure. The best hope is you develop Alzheimer's before osteoarthritis, so you won't even remember that you have one. Okay? Now, rheumatoid arthritis. That's different. That's the autoimmune disease. Okay? So, by the way, the Nobel Prize in Physiology and Medicine that was given this year was given to people who studied immune mechanisms that are, among other things, responsible for autoimmune diseases, okay, like T regulatory cells. So what effectively happens is that, remember those phagocytic cells, neutrophils, macrophages that are sitting in your joints? They become crazy and start attacking your synovial membrane. Okay? So that results in inflammation and swelling of the synovial membrane. And then listen, every inflammation, as we learned in the very early in course, inflammation has to result in the repair, whether it is needed or not. So the repair means formation of connective tissue, the scar tissue. So this is your scar tissue, okay? Fibrous ankylosis. Sounds good? And then if you don't move, that fibrocartilaginous tissue is replaced with a bony tissue, and that's it. There's nothing you can do about it. Again, there is no cure. There are treatments. So first of all, who's at risk? Women, mostly. We don't, well, I don't want to say we. I am not aware of any good studies that would provide the mechanism for why women have a greater risk for developing autoimmune disorder in general. Okay, we don't know. Does that make sense? Now, what's interesting is that various autoimmune conditions seem to have the common origin. One of my very good friends, actually, when he was in academia, he worked on autoimmunity, and when he moved to industry, pharmaceutical industry, he continued to work on autoimmunity. Turns out things like rheumatoid arthritis, psoriasis, inflammatory bowel disease, they sometimes can be treated with the same drug. I know it's a very, very specific. I watch a fair amount of Amazon Prime videos, and this greedy bitches started to insert a lot of advertisement. One of them is the drug called Tremfya. I don't know if you've seen it. In one ad, it's treating psoriasis. In another ad, it's treating IBD. It's all true. There are drugs that, because those conditions share the same pathogenesis, autoimmune disorder of the same mechanism, we don't know what triggers that autoimmunity. That makes sense? Like, okay, we kind of do, but it still doesn't help to prevent it. But treatment is there, and it extends the quality of life, includes. So, for instance, rituximab is the old drug. I don't think it is used anymore. Now there are drugs that are much more targeted, much more precise, and much better at minimally affecting your overall immune status. Okay? But again, gotta move. Gout arthritis. This is the nature's revenge against rheumatoid arthritis, because this affects mostly men. Okay? So what happens, uric acid, which is the product of the nucleotide breakdown, like DNA, RNA breakdown, uric acid is not excreted properly by kidneys and gets deposited in the joints. Okay? So there is a risk factor. There are two risk factors that both sound absolutely awesome. One of them is huge amount of protein being consumed, and second, alcohol. Okay, so basically, no more bourbon, no more barbecue. Well, but what do you mean? Processed meats contribute to a lot of other, for gout, it's animal protein for the most part. Okay? Also, I can't, like, you really have to carve out a very special diet to consume a huge amount of plant-based protein, just because plants aren't as protein-rich as, say, beef or pork. Okay? Again, go ahead.
So supplements, do those work for
No.
this?
No.
I know a person that
No.
has spent so much money on supplements for that.
No.
Yeah.
The gout is not, like, the problem is, there is a legitimate catabolic product called uric acid. I believe, I read about it recently, and I can't remember shit. There's something with the kidney transport of uric acid out of the blood into the urine that can be impaired, even at the genetic level. So kidneys fail to excrete it properly, so it just basically diffuses from the blood into the joint and forms crystals. And it's like somebody poured a fair amount of sand into a joint. Okay? No, nothing really helps. You have to avoid alcohol. My dad had gout for the last 10, 15 years of his life. At some point, like when we visited, he would say, dude, like, I appreciate that, but I'm not having a drink with you. Okay, like, I'm going to abstain because it's going to be painful for a couple of days for him. This is here only because I love bugs, not like insects, but I'm talking about ticks. I'm talking about microbes. There are actually quite a few infectious causes of arthritis. So Lyme disease is one of them. This map is old and now wrong. It shows you, this is the distribution of Lyme disease like 10 years ago. Now Lyme disease is everywhere in Ohio. It finally migrated. Okay? Yeah, I support that. So let me finish with Lyme disease, and I'm going to comment on ticks in general. So this Ixodes scapularis tick, after a tick bite, you may see this bullseye rash. Or may not. May not. So, whatever. Also, ticks prefer places where it's wet and warm and dark and quiet. So it's your hair, it's your armpits, it's your groin. They deliberately crawl there. Maybe this behavior was effective because it's much easier to spot a tick on like a hand than it's, in the armpit. Okay? Other conditions that can cause, so this thing, Lyme disease, if it's not treated timely, it infects joints, and it's pretty much chronic arthritis. Okay? Other things that can cause arthritis, but we're talking about like super advanced disease. Gonorrhea. Untreated gonorrhea can result in the arthritic symptoms. Strep throat. Untreated strep throat may result in rheumatoid arthritis eventually. At this point, joints is your least concern. So it's all about the heart and kidneys. Okay? Now about the ticks, a few words before we wrap up. First of all, only about 1% of ticks, not less, carry any type of disease. In the state of Ohio, in addition to Lyme disease now, there's an infection called anaplasmosis, the one you should be aware of. It to my knowledge, it affects dogs more than humans, like it's worse. Okay? And also another thing, ticks are slow. So if you notice a small tick that sits on your dog, the chances are it did not have serious contact with blood. If it's engorged, like full of blood, yeah. If you spot it early and remove it, chances are practically nothing.
Why? I see that sometimes people with Lyme disease, they treat it with like stings.
Do what?
Like they like take like bees and then make them sting, and apparently something in like their like venom or something helps to treat symptoms. I've seen it. Like it's
I've never heard of it.
Yeah.
I'm not going to critique something that I have no idea about. I don't know.
Okay.
It's entirely possible, but the thing is, it's a systemic infection. It's a blood infection. It basically, the bacteria go into the blood and then spread around and affect mostly, have mostly neurological and arthritic effects. So unless it somehow prevents the local spread from that bullseye rash that I showed you, I can't think of any physiological mechanism that could help you, that bee stings work through. The pain, maybe it works pretty much the same way as capsaicin creams, the creams that contain pepper effectively. They just block the pain. They're not really treating the cause. Symptoms, totally possible.